There we go. If you're dialing via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DOR board members reserve questions until the end of presentations or ask in the Google Meet chat. Those providing public comment, if you'd like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. And thank you. All right, so now we'll move on with the rest of the agenda. And the first item of business, we have the approval and review of the November DUR minutes. Is there a motion for the November DUR minutes to be approved?
Move to approve.
Thank you, Dr. Kennington. Can I get a second?
I'll second.
Thank you, Dr. Siegfried. Any opposed? All in favor? Any abstentions?
Aye.
All right, thank you so much. Motion passes to approve. And then one item of housekeeping that I didn't put in the agenda, I forgot to put it in, but I just wanted to mention. Mr. Cordero Baxter is no longer part of the DUR board. I have not been able to communicate with him for the last few months. And so we have the consumer representative position still vacant. So if you have anyone in mind that you'd like to recommend, please send that information my way. And then regarding the prior authorization updates, so all of the November prior authorization forms that were reviewed have been submitted for posting. And then I'm here to report on the PNT committee update. Dr. Nguyen is on vacation. So the PNT committee met in November to discuss non-factor products for hemophilia prophylaxis therapy. The committee will meet in February to discuss GLP-1 agonists for weight loss. And with that, we'll continue to the next portion of the agenda, which is public comment. So we have some people providing public comment today. First, we'd like to begin with Dr. Christine DURB. She will be providing public comment on their Supra. She'll be followed by Dr. Mark Harmon, who will be talking about Rinvoq and Rinvoq LQ. And then he will be followed by Logan Poole, who will be providing comment on Wegovy. And lastly, we'll hear from Dr. Juliana Simonetti, who will be speaking to us about GLP-1s for MASH. Dr. DURB, are you here today?
Yes, can you hear me?
Yes.
Okay, sorry, I wanted to make sure you could hear me. So, good morning, everyone. My name is Chris Dubé, and I am a PharmD with the medical affairs employed by AstraZeneca. I want to thank you for this opportunity to present information today on their Supra pressurized metered-dose inhaler containing albuterol and budesonide 180-160 micrograms. The information I will discuss is provided to support the movement of AirSupra to a preferred position as rescue therapy per the GINA guidelines to use ASAVA and IS containing whenever rescue therapy is required. Air Super is a fixed dose combination inhaler containing albuterol and budesonide and is indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma aged 18 and older. It is the only rescue agent currently available in the United States indicated to reduce the risk of exacerbations. I'd like to call to the committee's attention several things about the GINA guidelines. The Global Initiative for Asthma or GINA recommend the concomitant use of as-needed SABA and ICS in separate or combination devices across all steps of therapy. We know that Air Super was studied, and in our study, in patients with moderate to severe asthma, we saw 28% reduction in the risk of exacerbations. And importantly, in those patients with mild intermittent asthma, we saw a 46% reduction in the risk of severe exacerbations. As a reminder, GINA does recommend the use of an ICS SABA whenever a SABA is recommended across all steps of therapy versus just using a SABA alone. And based on today's testimony, AstraZeneca respectfully requests that Air Super be added to the preferred list on the Utah PDL. Thank you. Any questions, please let me know.
Thank you. Thank you, Dr. Dube. Are there any questions from the board? Thank you so much. Now let's hear from Dr. Harmon. Hello, Dr. Harmon, are you here? Okay, is Dr. Poole here then? Or Wegovy?
I'm here. Can you hear me?
Yes.
Okay, perfect. Good morning, everybody. My name is Logan Poole. I'm a PharmD and Medical Account Director with Novo Nordisk. I really appreciate the opportunity this morning to provide you with an update on a new FDA indication for Wegovy, the semaglutide 2.4 milligram injection in patients with MASH, known as metabolic dysfunction-associated hepatitis. As you recall, Wegovy was initially approved in 2021 for weight management in adults and subsequently in pediatric patients aged 12 years and older. This was followed in 2024 with an indication to reduce MACE in adults with ASCVD and overweight or obesity. As new this year, on August 15th, Wegovy received the indication for non-cirrhotic metabolic dysfunction-associated steatohepatitis in patients with moderate to advanced liver fibrosis, consistent with the F2, F3 fibrosis stages. This indication was approved under accelerated approval based on histological improvements in MASH and fibrosis, while the confirmatory trial based on clinical endpoints is ongoing. Now, MASH is a silent progressive disease in which fat infiltrates the liver and leads to inflammation and fibrosis or scarring. Disease progression can lead to cirrhosis of the liver, liver cancer transplantation, and death. And unfortunately, real-world data suggests that only 1 in 20 patients with MASH are diagnosed. In the pivotal Essence trial, 800 patients with MASH and F2 to F3 fibrosis were randomized to semaglutide or placebo. Patients underwent histological biopsy assessment at baseline and at 72 weeks. Semaglutide was superior to placebo in both the co-primary histological endpoints of MAS resolution and fibrosis reversal. There were no new safety signals identified in the trial. That said, I'd like to highlight 2 important things regarding the updated Wegovy label for MASH. The liver biopsy, despite this being used for purposes of the trial, is not recommended in the label for diagnosis or monitoring. Rather, non-invasive tests such as FIB4, LSM, or ELF scores are generally recommended per the clinical practice guidelines. The second thing is the presence of obesity and overweight is not a requirement for MASH treatment with Wegovy, as a subset of patients enrolled in the Essence trial had lean MASH. To conclude, I respectfully ask the committee to consider adopting coverage for the criteria for Wegovy for MASH, which would permit access for individuals living with chronic progressive disease. Thank you for your time, and I'm happy to address any questions.
Thank you, Dr. Poole. Any questions from the board? Okay, thank you. And Dr. Harmon, are you here? All right, he emailed me a couple of minutes ago, so I sent him the link. So he might still be coming.
Yeah. Can you guys hear me now?
Oh, there we go. Yes, we can hear you.
Excellent. Thank you so much. Yeah, I apologize for that. I realized this morning I did not know the link to get in, so.
All right, go ahead, Dr. Harmon.
All right. Thank you so much. Yeah, my name is Mark Harmon. I'm one of the pharmacists that works with AbbVie. I'm a medical outcome science liaison. And thank you for the opportunity for letting me discuss Rinvoq today. So currently Rinvoq is classified as a non-preferred treatment on Utah Medicaid's PDL. I respectfully request that Rinvoq be added to the preferred list, aligned with its approved indications and labeling. Presently, only 2 JAK inhibitors, Xeljanz and Olumiant, are preferred on the PDL, covering a total of 7 indications. Rinvoq alone has 9 indications, including one of them as atopic dermatitis or eczema, which is not currently covered by the preferred JAK inhibitors. For a moderate to severe atopic dermatitis, the only systemic options on your PDL are injectable monoclonal antibodies, including Dupixent and Adbry, and there are no preferred oral systemic therapies. We can see from the head-to-head clinical trial that Rinvoq is a better option than Dupixent in treating atopic dermatitis. If we look at the Level Up trial, Rinvoq showed superior results to Dupixent, with more than twice the number of patients achieving the primary outcome in both EASI-90 and WP-NRS 0-1 at week 16. Meaning patients were twice as likely to have at least a 90% improvement from baseline in their eczema symptoms and either no or almost no itch in the Rinvoq arm of the study versus the Dupixent arm of the study. Again, Rinvoq shows superiority in the treatment of atopic dermatitis versus one of your approved systemic therapies on the PDL, and it by itself has more approved indications than the combined 2 JAK inhibitors listed on that same PDL. Therefore, I just request that Rinvoq be granted preferred status as a JAK inhibitor on Utah Medicaid's PDL. So thank you for your consideration. I'm happy to answer any questions.
Thank you, Dr. Harmon. Any questions for Dr. Harmon on the board? Okay, thank you. And I will move on to Dr.
Thank you.
Simonetti. Thank you.
Hi, good morning, everyone. Thank you for having me here this morning. I'm Dr. Simonetti. I am the director of the Comprehensive Weight Management Program here at the University of Utah, and I do treat many patients with obesity and obesity-related complications, and one of them being MASH. We also see many patients. We have a transplant group here at the University of Utah, so unfortunately, we are seeing an increased number of patients requiring liver transplant related to MASH. So find it extremely important that we are screening patients appropriately, but also treating them appropriately before they get to the level of cirrhosis. And as you all know, that about 20% of patients that have, we have an average of the population with 20% of the population that has metabolic complications having fatty liver disease. However, only about 5 to 6% of those ended up with steatohepatitis, and then even a smaller percentage of that ended up with fibrosis level 2 to level 3. At our clinic, we have been using measurements such as FIT4. We calculate by obtaining blood work. It requires platelets plus CMP. And then we also have a FibroScan and is readily used. We are seeing an increased number of physicians and providers using FibroScan to identify fatty liver disease as well as fibrosis. So I do ask the board to take those things into consideration. And obviously, it's a lot cheaper to treat patients with one of the medications currently available. And we had been seeing this in clinical practice for quite a few years now, where patients, when they are getting GLP-1s, they tend to do a lot better. They're losing weight and improving the metabolic risk, but also we are seeing the significant improvement on their liver health. So I'll stop here and be open for any kind of questions.
Thank you. Any questions for Dr. Simonetti from the board? All right. Thank you for providing all those participated to provide public comment for the board. We appreciate your time today. Now we'll move on to the review of the new prior authorization criteria. So today we have 4 new forms for the immunomodulators that we were covering last time. We have 4 new forms today to review, followed by Wegovy for the treatment of MASH, and then Airsupra prior authorization form. So I'm the first one on the list to present. So I'll start with Opzelura, and I will share. Can everybody see the form Opzelura?
Yes.
Okay, thank you. All right, so this is Opzelura as a JAK inhibitor cream, and it follows similar criteria as the other immunomodulators. So the first criteria for approval here is the patient 2 years of age or older. Does the patient have any of the following diagnoses demonstrated by description of baseline symptoms present in the chart notes? Mild to moderate atopic dermatitis with involvement estimated to be greater or equal to 3% of the body surface area, or less than 3% of BSA with atopic dermatitis involvement to face, eyes, eyelids, skin folds, and or genitalia. Non-segmental vitiligo, 12 years of age or older only, and then other off-label or compendia use. Is the medication being prescribed by or in consultation with a dermatologist, allergist, immunologist, or provider specializing in disease treatment? Has a member tried and failed at least one medium to super high potency topical corticosteroid and a topical calcineurin inhibitor at a minimum of 4 weeks? And if involvement to the face, eyes, eyelids, skin folds, and or genitalia, trial and failure of TCS is not required. Does the requested medication and diagnosis follow FDA approved age dosing, monitoring, and contraindications? If no, go to Part 2, Section 7, which is the off-label criteria that we have. Does the provider attest that the patient is not taking concurrent treatment or will not be used in combination with other therapeutic biologics, JAK inhibitors, or immunosuppressants such as azathioprine or cyclosporin? And then here's the off-label criteria that we have. Does the clinical documentation show an adequate trial and failure of at least one FDA-labeled and Medicaid preferred medication if applicable? Does the provider attest the requested drug is being used for a medically accepted indication that is supported by information from the appropriate compendia of current literature, including at least one major multi-site study or 3 smaller studies published in JAMA, in JAM, Lancet, or other peer-reviewed specialty medical journals in the most recent years? And then the compendia used must be recommended by generally accepted compendia such as American Hospital Formulary Service Drug Information, United States Pharmacopoeia Drug Information, the Micromedics Information System, Pediatric and Neonatal Lexi Drugs, or clinical guidelines. For the reauthorization criteria, has the provider submitted updated chart notes demonstrating the patient has had a positive clinical response, including reduced BSA involvement and improvement in symptoms. And it'll be authorized initially for up to 6 months, and then the reauthorization up to 1 year. And down here are notes for the block box warnings. And are there any questions or discussion from the board? Okay, hearing none, then can I get a motion to approve the criteria for Opzelura as presented?
I'll motion.
I'll second.
Thank you, Dr. Britton and Dr. Smith. All in favor?
Aye.
Aye.
Any opposed? Any abstentions? All right, motion passes to approve the criteria as presented today. Thank you so much. The next PA form is Rinvoq and Rinvoq LQ. So that's the liquid formulation. And let me go to the top here. All right, criteria for approval. All of the following criteria must be met. Then move to part 2. Is the medication being prescribed by in consultation with a provider specializing in the disease? Let's see, Dr. Siegfried. Yes, Dr. Siegfried?
Sorry, I'll be sending the message in a minute.
Okay, thank you. All right, so the first question is regarding the provider specializing in disease treatment. Number 2, and then does the patient have any of the following diagnoses? And there's a list of the diagnoses there. Does the provider attest that the patient is not taking concurrent treatment or will not be used in combination with other treatments, biologics, as listed there? Number 4, does the requested medication and diagnosis follow FDA-approved age, dosing, monitoring, and contraindications? And so this is the question that refers to if no, then they can fill out the portion for the non-FDA label indications. Number 5, has the patient tried and failed for at least 3 months, 2 months for ulcerative colitis, demonstrated an intolerance to or has contraindication to the preferred TNF if applicable? Note, this criteria is not applicable for atopic dermatitis and giant cell arteritis. Number 6, if requesting Rinvoq LQ, does the provider attest that the requested dose cannot be achieved with a tablet and that it is being prescribed for PSA or PJIA? Part 2, and so these are the sections for the specific disease states. Additional criteria for ankylosing spondylitis. All the following criteria must be met. The patient at least 18 years of age or older. Does the patient have a diagnosis of ankylosing spondylitis demonstrated by the description of baseline symptoms present in the chart notes? Section 2 is for atopic dermatitis. Is the patient at least 12 years of age or older? Does the patient have a documented diagnosis of refractory, moderate to severe atopic dermatitis with involvement estimated to be greater or equal to 10% of the body surface area, or less than 10% of BSA with atopic dermatitis involvement to the face, eyelids, eyes, skin folds, and/or genitalia? Has the patient tried and failed demonstrated an intolerance to or has a contraindication to the preferred Adbry or Dupixent? Number 3, Crohn's disease. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of moderately to severely active Crohn's disease as confirmed by applicable testing such as diagnostic imaging, inflammatory biomarker, or disease activity scale, and supported by a description of baseline symptoms, labs present in the chart notes. The next section, number 4, is for giant cell arteritis. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of giant cell arteritis confirmed by biopsy or imaging, demonstrated by description of baseline symptoms presented in the chart notes? Section 5 refers to the non-radiographic axial spondyloarthritis. Is the patient at least 18 years of age or older? Does the member have a, I'm going to switch that to patient, have a diagnosis of active non-radiographic axial spondyloarthritis with objective signs of inflammation demonstrated by description of baseline symptoms present in the chart notes? Number 6, for polyarticular juvenile idiopathic arthritis, PJIA, is the patient at least 2 years of age or older? Does the patient have a diagnosis of mildly severely active polyarticular juvenile idiopathic arthritis demonstrated by description of baseline symptoms present in the chart notes? If the request is for Rinvoq LQ, does the patient weigh less than 30 kilograms? Number 7, psoriatic arthritis. Is the patient at least 2 years of age or older? Does the patient have a diagnosis of active psoriatic arthritis demonstrated by the description of baseline symptoms present in the chart notes? If the request is for Rinvoq LQ, does the patient weigh less than 30 kilograms? Section 8, additional criteria for RA. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of mild to severely active rheumatoid arthritis demonstrated by the description of baseline symptoms present in the chart notes? And then finally, number 9, for UC, is the patient at least 18 years of age or older? Does the patient have a diagnosis of moderate to severe ulcerative colitis as confirmed by applicable testing such as diagnostic imaging, inflammatory biomarker, or disease activity scale, and supported by description of baseline symptoms labs present in the chart notes? And then section 10 is the off-label criteria that we've already covered in the previous PA form. And then the reauthorization criteria has a provider submitted updated chart notes demonstrating positive clinical response, and it'll be authorized up to 6 months initially, followed by a reauth up to 1 year. And then the warnings are down here. Any questions regarding the criteria for Rinvoq or Rinvoq LQ? Again, Noon was the one that updated recommendations made last time for the other immunomodulator forms, and so it's pretty much following the same formatting. Yes, Dr. Smith.
Hi, good morning.
Morning.
On number part 2, section 2, number 3, I'm just wondering if we want to list specific agents or just say the preferred agent in case, so you don't have to change this PA form if the preferred agents change.
Oh, okay. That's a good point.
That's all I had.
Thank you. So maybe preferred immunomodulators for
For the indication, yeah.
all right. Thank you so much. So can I get a motion to approve the criteria as presented today?
I'll make that motion.
Thank you,
A
Dr.
second.
Thank you. And then all in favor?
Aye.
Aye.
Thank you. Any opposed or abstentions? Thank you. Motion passes to approve rainbow criteria as presented today. All right. So next on the agenda is tying and biosimilars PA form. And that will be presented by Dr. Ashley Park.
All right, good morning, everyone. I'll be presenting prior authorization criteria for Tyen. Okay, so for the first question, they can choose what medication they're requesting. So Tyen is preferred, and then other ones are non-preferred. But if they're requesting for Actemra for systemic sclerosis associated interstitial lung disease, they have a separate requirement for the non-preferred product, and then the additional criteria in Part 3 is not required. Is a medication being prescribed by or in consultation with a provider specializing in the disease treatment? Does the patient have any of the following diagnosis? And then they can choose the indications. And does the requested medication and diagnosis follow FDA-approved age, dosing, monitoring, and contraindications? And if the answer is no, they can go to Part 2 and Section 5 to fill out the off-label criteria. Does the provider attest that the patient is not taking concurrent treatment or that the medication will not be used in combination with other TNF inhibitor, biologic response modifier, or other biologic DMARDs, Janus kinase inhibitors, or phosphodiesterase 4 inhibitor as verified by prescriber attestation, member medication field history, or submitted by documentation. Additional criteria for giant cell arteritis. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of giant cell arteritis confirmed by a biopsy or imaging demonstrated by description of baseline symptoms present in the chart notes? Will the requested medication be used in combination with tapering course of glucocorticoids? Has the patient tried and failed for at least 3 months, demonstrated an intolerance to, or has a contraindication to methotrexate if clinically appropriate? Additional criteria for polyarticular juvenile idiopathic arthritis or systemic juvenile idiopathic arthritis. Is the patient at least 2 years of age or older? Does the patient have a diagnosis of moderately to severely active polyarticular juvenile idiopathic arthritis or systemic juvenile idiopathic arthritis demonstrated by description of baseline symptoms present in the chart notes? Has the patient tried and failed, demonstrated an intolerance to, or has a contraindication to one NSAIDs or glucocorticoid for 3 months? Has the patient tried and failed, demonstrated an intolerance to, or has a contraindication to methotrexate or leflunomide for 3 months if clinically appropriate? Additional criteria for rheumatoid arthritis. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of moderate to severe active rheumatoid arthritis demonstrated by description of baseline symptoms present in the chart notes? Has the member tried and failed, demonstrated intolerance to at least one disease-modifying anti-rheumatoid drug for at least 3 months, or contraindication to all if clinically appropriate. Additional criteria for systemic sclerosis associated interstitial lung disease. Is the patient at least 18 years of age older? Does the patient have a diagnosis of the disease demonstrated by a description of baseline symptoms present in the chart notes? And then section 5 is the off-label use, and then the languages are the same with the previous PA criteria. And then for the non-preferred criteria, for request of brand, Actemra, or non-preferred biosimilar, has the patient tried and failed the preferred tocilizumab products? And then this one does not apply to the interstitial lung disease. And for reauthorization criteria, has the provider submitted updated chart notes demonstrating positive clinical response? Initial authorization up to 6 months, reauthorization up to 1 year, and here's the box warnings. Okay, any questions? Okay, I hear none.
All right, thank you. And now can I get a motion for approval of this criteria as presented?
Move to approve.
Thank you, Dr. Smith.
I'll
I get a
second.
Thank you, Dr. Siegfried. All right, all in favor?
Aye.
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 Thank you. Any opposed? Any abstentions? Thank you, motion passes.
All right, I will present the next one. This is Cell-Jans XR, and Cell-Jans solution. So is the medication being prescribed by or in consultation with a provider specializing in the disease treatment? Does the patient have any of the following diagnoses? And then they can choose the diagnosis here. Does the provider attest that the patient is not taking other concurrent treatment, or that the medication will not be used in combination with other TNF inhibitor, biologic DMARD, Janus kinase inhibitors, or PDE4 inhibitor, as verified by prescriber attestation, member medication field history, or submitted documentation? Does the request medication diagnosis follow FDA-approved age, dosing, monitoring, and contraindications? And if it's no, they can go to Part 2 and Section 6 and they fill out the off-label indication. Has the patient tried and failed for at least 3 months and 2 months for ulcerative colitis, demonstrated an intolerance to or has a contraindication to the preferred TNF if applicable? If requesting Cell-Jans solution, does the provider attest that the requested dose cannot be achieved with a tablet and that it is being prescribed for PJIA, which is the polyarticular juvenile idiopathic arthritis? Additional criteria for ankylosing spondylitis. Is the patient as at least 18 years of age or older? Does the patient have a diagnosis of ankylosing spondylitis demonstrated by description of baseline symptoms present in the chart notes? Has the patient tried and failed, demonstrated an intolerance to, or has contraindication to at least 2 different prescription strength and says as the maximally tolerated dose for at least 1 month each? Additional criteria for polyauricular juvenile idiopathic arthritis. Is the patient at least 2 years of age or older and weighs 10 kilograms or more? Does the patient have a diagnosis of moderately to severely active polyarticular juvenile idiopathic arthritis demonstrated by description of baseline symptoms present in the chart notes? Does the patient have a trial failure, intolerance, or contraindication to 1-NSAID or glucocorticoid for 3 months? Does the patient have a trial failure, intolerance, or contraindication to methotrexate or leflunomide for 3 months if clinically appropriate? If the request is for Seljan solution, does the patient weigh less than 40 kilograms? Additional criteria for psoriatic arthritis. Is the patient at least 2 years of age or older? Does the patient have a diagnosis of active psoriatic arthritis demonstrated by description of baseline symptoms present in the chart notes? Has the patient had an adequate trial and failure of at least one of the following DMARD for at least 3 months unless all are contraindicated? Those include methotrexate, leflunomide, sulfasalazine, azathioprine if clinically appropriate. If the request is for Seljan solution, does the patient weigh less than 40 kilograms? And then the additional criteria for rheumatoid arthritis. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of moderately to severely active rheumatoid arthritis demonstrated by description of baseline symptoms present in the chart notes? Has the member had an adequate trial and failure of at least one disease modifying anti-rheumatic drug for at least 3 months? Those are, for example, they can be hydroxychloroquine, leflunomide, methotrexate, sulfasalazine, or contraindication to all if clinically appropriate. Additional criteria for ulcerative colitis. Is the patient at least 18 years of age or older? Does the patient have a diagnosis of moderate to severe ulcerative colitis as confirmed by applicable testing such as diagnostic image, inflammatory biomarker, or disease activity scale, and supported by description of baseline symptoms and labs present in the chart notes? Has the member had an adequate trial and failure of at least one of the following for at least 2 months or has contraindication to all? And those are high-dose oral 5-aminosalicylic acid drug and topical 5-aminosalicylic acid drug. And then this is section 6, other off-label or compendia use. Those are the same language with the previous one. And part 3 is for Seljan's solution. For the request of the Seljan solution, has the patient tried and failed on oral tablet, or is there a clinical rationale for using the solution? And reauthorization criteria, has the provider submit updated chart notes demonstrating possible clinical response? Initial authorization up to 6 months, reauthorization up to 1 year, and then here's the black box warning. Okay, and then that's it. Any questions? Oh yeah, Dr. Smith.
Yeah, hi. I was wondering about the language about the 40 kilos in the solution down at the, sorry, scooch up a little bit, but yeah, I think that's where it is. Anyway, so you said, is there a reason they're using the solution and not the tablet? And I think besides dosing, you said, or other clinical indications on the lower part, but not at the top part, because I'm thinking about people with like feeding tubes, for example. So you have, is there a clinical rationale for using this solution? But it doesn't say that at the upper part where the person is under 40 kilos. Does that make sense?
Oh yeah, it makes sense. Yeah, we can add the clinical rationale part to like section 2 and 3.
Perfect.
Yeah.
Thanks.
Yeah. Okay, any other questions?
Thank you, Dr. Park, for presenting. And is there a motion to approve the criteria as presented with the recommended modification?
I can motion.
Thank you, Dr. Britton. Can I get a second, please?
Second.
Thank you, Dr. Smith.
Thank you.
All right, all in favor?
Aye.
Any opposed or abstentions? Thank you, motion passes. And now we're moving on to Wegovy, and that will be presented by Dr. Iris Wan, and she'll be followed by Dr. Skylar Fenton on Air Supra.
Morning. Good morning, everyone. Can everyone see my screen? Great. Okay, so I have Wegovy for the treatment of non-cirrhotic metabolic dysfunction associated steatohepatitis or MASH. The first criteria is a patient 18 years of age or older? Is a medication being prescribed by or in consultation with a gastroenterologist, hepatologist, or other liver disease specialist? Does the patient have a diagnosis of metabolic dysfunction associated steatohepatitis, MASH, or formerly known as non-cirrhotic, non-alcoholic steatohepatitis or NASH? Does the patient have moderate to advanced liver fibrosis, stage F2 to F3, as confirmed by a FIB-4 score consistent with stage F2 or F3 fibrosis adjusted for age, and one of the following: a liver biopsy, fibration control, transient elastography, enhanced liver fibrosis or ELF score, magnetic resonance elastography, MRE. Does the provider attest that the patient does not have any of the following: decompensated cirrhosis, moderate to severe hepatic impairment, Child-Pugh score of B and C or C, any other liver disease such as hepatocellular carcinoma or hepatitis? Does the provider attest that the patient will use the medication in conjunction with lifestyle modification, including structured nutrition and physical activity? Does the provider attest that the patient will not be taking another concurrent glucagon-like peptide-1 receptor agonist or GLP-1? And then for the reauthorization criteria, has the patient been adherent to and is committed to make lifestyle modification, including structured nutrition and physical activity? Is the patient maintained on either Wegovy 2.4 milligram or 1.7 milligram weekly if higher dose cannot be tolerated after 17 weeks of treatment initiation? Has the provider submitted updated chart notes demonstrating the patient has had positive clinical response, including improvement in symptoms and or improvement in routine monitoring such as FIB-4 score, serum aminotransferases? And then for initial authorization, it's up to 6 months. For reauthorizations, up to 1 year. And then we just provided the black box warning right here in the note. Are there any questions, concerns? Yes, Dr. Simonetti.
Just a question. I am, like I said, I see many patients with metabolic dysfunction, and we do screen and treat patients for hepatic steatohepatitis. And I'm not a gastroenterologist. Is that a absolutely requirement? Because I think that, you know, that does make things a little more difficult. Sometimes the patients cannot get in, and the hepatologists are quite busy in our clinic practice too, and sometimes can take months for them to get in. So could it be, I know what you had some other criteria on prior medications. Could it be that you said, or or physicians who treat this condition only?
Yes. So we would consider if there's like a liver disease specialist. So
Thank you.
yep. Dr. Britton.
I was just going to say that it could be in consultation with, so it doesn't have to be that the patient is actually seen.
Yes, correct. Thank you. Any other questions, concerns? Dr. Smith?
Yeah, I looked at this extensively and went back and forth on whether there should be a way to request it outside of age indications, considering that this is showing up in adolescence. I just wondered if anyone had any thoughts on that. They're really.
Dr. Britton?
I was just going to ask a question to follow up. Is there a process or is there something, so you're saying for age indications, off-label consideration? I think for EPSDT, for pediatric patients, that the medication has to be reviewed for medical necessity. So I think you're covered under EPSDT. I don't know if it has to be outlined here, but if that was your concern.
Yeah, I guess I'm not sure if it's obvious.
Yeah, generally, if it's off-label, we'll review it as like an off-label indication, like we would with other medication. But if it was otherwise denied, there is a way to get or be reviewed under EPSDT. Any other questions, concerns?
All right, thank you, Dr. Wan. And thank you for those questions, for your participation. And is there a motion to approve the criteria as presented today?
I'll motion.
Thank you, Dr. Britton. And is there a second?
Second.
Thank you, Dr. Smith. All in favor?
Aye.
Aye.
Thank you. Any opposed? Any abstentions? Thanks, everyone. So now we're up to our final PA form review.
Good morning. Let me just get this shared. Okay. Yeah, I'm Skylar Fenton. I'm gonna go over Air Supra. Just a little background on this one. Currently, Air Supra has been placed as like a non-preferred in the short-acting beta agonist drug class, meaning in order for someone to get prescribed this, the criteria is basically kind of like a trial and failure of like an albuterol inhaler. So the purpose of this prior authorization form is to better align with the GINA guidelines on where this medication fits. And yeah, so it's relatively short criteria, but is a patient 18 or older, as that's what it's indicated for. Does the patient have a diagnosis of asthma? And then number 3 is, has the patient had an inadequate response, intolerance, or contraindication to a minimum 30-day trial of a formoterol inhaled corticosteroid, or excuse me, formoterol plus inhaled corticosteroid combination products such as Dulera or Symbicort used for as-needed symptom relief. Formoterol, it is a long-acting beta agonist, but it is one that acts quickly, so the GINA guidelines have that one as a potential option for as-needed use. And then that's basically it. Does anyone have any questions on this one? Yes, Dr. Smith.
Yeah, so in the use of this type of agent, the GINA guidelines recommend it for people as young as 12. And although not part of the age indication, they did include patients 12 and older in some of the studies published in New England Journal. There weren't a ton of them, but they were in there. And yeah, I just wondered how to sort of reconcile that, basically. The other thing was I questioned the need for a 30-day trial. When someone has had a recent exacerbation, they would definitely not wait 30 days to switch them to something else. And then lastly, sorry, there's a few things here. I would add in here verification of inhaler technique with like the inadequate response intolerance, basically saying has inhaler technique also been verified?
Yeah, that makes sense. I think regarding the GINA guidelines and like if there's an exacerbation, it's a little funny because like if there's an exacerbation, that's kind of when they should be moved up a step and start using like a controller inhaler with regular use, and then as needed can then like be later assessed. So it's kind of tricky how this one fits in the guidelines with respect to that 30-day trial kind of thing.
I know it's usually 7.
7.
Mm-hmm.
Gotcha. Yeah. Well,
Because they try to get control as quickly as possible if they've had a recent exacerbation.
right. Well, thanks for your feedback. We'll definitely like, especially that inhaler technique. That seems like a good one to include too. Yes, Dr. Britton.
I would just, again, on the age thing, suggest that that also would be covered under EPSDT, medical necessity, off-label coverage that could be considered on review. But I like the addition of the inhaler technique, and I would not be opposed to changing 30 days to 7 days.
Awesome. Thank you.
All right, great discussion. Thank you so much, Dr. Fenton, for the presentation. So just to summarize, for Dr. Smith's questions, we will leave the age of 18 per label for number 1, and is there still a way that younger patients can get it covered through EBSET? And then also the board agrees to change the trial failure of a previous rescue inhaler from 30 days to 7 days. And then also to add a question regarding, has the patient been instructed on proper inhaler technique? Is that right?
No, I would verify appropriate inhaler technique.
Oh, verify.
Not just instruct.
Demonstration of proper. Mhm.
Okay. Excellent. Thank you so much. So we'll be working on those amendments. And other than that, does the board, can I get a motion to approve this criteria for Air Supra as presented?
So moved.
Thank you, Dr. Smith. Can I get a second, please?
I can second.
Thank you, Dr. Britton. All in favor?
Aye.
Aye.
Thank you. And any opposed or any abstentions? All right. Thank you very much. So yes, we'll end a few minutes early today. The next meeting is will be January the 8th, 2026. I had a typo, 2025 on the agenda, so 2026. And the topic will be combination treatment with Botox and calcitonin gene-related peptide antagonist in the setting of chronic migraine. And I missed Dr. Weinstein today, but hopefully she'll be back with us in January. Can I get a motion to adjourn the meeting?
So move.
Thank you, Dr. Brinton. And can I get a second?
Second.
second.
Thank you. All right. Well, have a happy holiday season and see you all next year.
See you later.
Thank you. Bye.
Thank you.